Good afternoon. I'm Dr. Joshua Royce. I'm a thoracic medical oncologist at Georgetown University. I'm fortunate to be joined by one of my colleagues, Dr. Patrick Ford from Johns Hopkins. In the prior session, we discussed a case of advanced unresectable malignant pleural mesothelioma and outlined the treatment options for these patients. And in this session, we're going to discuss a case of a patient with potentially resectable mesothelioma. This is an important case to discuss because as we learn more about this disease, we do realize that there are patients that benefit from a more aggressive approach incorporating surgery plus or minus chemotherapy and radiation. So in this case, this is a 64-year-old gentleman who has never smoked with a past history of sleep apnea and depression who presented to the emergency room with a 1-month history of worsening shortness of breath and night sweats. Of note, he has worked for 40 years as a hospital radiology technician and does report asbestos exposure. Imaging at the time revealed a large right-sided pleural effusion. Initial thoracentesis demonstrated an exudative effusion with negative cytology. Unfortunately, the effusion recurred in a subsequent CT chest, and a subsequent CT chest demonstrated an effusion with associated right-sided pleural thickening. An ultrasound-guided thoracoscopy with pleural biopsy demonstrated atypical cell proliferations with focal chondroid change with multiple foci of calcification and atypical mesothelioma proliferation and nests. The atypical cells were positive for cytokeratin, WT1, and calretinin with loss of BAP1, consistent with malignant pleural mesothelioma. A biphasic histology was identified with 10 to 15% epithelioid component and 85 to 90% sarcomatoid component. So what this is initially illustrating with, again, localized pleural thickening is potentially a patient who might benefit from a more aggressive resectable approach. So I want to bring in Dr. Ford. What additional things would you be looking for in deciding whether a patient has potentially resectable disease, number one? And number two, what are you going to say to oncologists who, maybe rightfully so, would say, well, there's no benefit, there's no clear data to support surgery in patients with mesothelioma. Why would we even pursue this to begin with?
Yeah, I think, Josh, both are good questions. I think to answer your second question first, I think given mesothelioma is a very rare disease, it's true, we don't have large randomized clinical trials comparing surgery with no surgery for this disease. However, in centers with experience for mesothelioma, longitudinal follow-up of patients who undergo surgery for mesothelioma does suggest improved survival, anything from 2 to 3 times the expected survival for unresectable mesothelioma in patients who have had a surgical procedure. Now, that again has to be individualized to the patient in front of you in terms of their performance status, the extent of their disease, as you mentioned, and the histology. For this particular patient, I think further investigations might include a PET-CT scan, for example, to try and pin down the extent of disease, particularly in the mediastinum and the contralateral side of the chest. The other question that arises traditionally we have reserved surgery for patients with epithelioid disease. There have recently been some changes to the NCCN guidelines in this regard, in that for very selected patients with good performance status who have biphasic histology, surgery may have some benefit. And I think that approach could be considered in this patient if he has confined disease.
Excellent. So with that, we'll move on to the additional evaluation that was done. So as Dr. Ford pointed out, important to get a PET-CT to assess full extent of disease, and this was obtained in this patient, which demonstrated mildly hypermetabolic soft tissue pleural thickening with associated calcifications in the right lower lobe, in addition to minimally enlarged mediastinal lymph nodes with mild FDG avidity. There was no evidence of distant metastatic disease. So with the FDG-avid mediastinal lymph nodes, a VATS was performed with mediastinoscopy. 4 mediastinal lymph nodes were sampled and negative for malignancy. PFTs were performed as well, which revealed mild restrictive ventilatory defect and modest diffusion impairment, but did not preclude in any way potential surgical resection. So with this information in mind, Dr. Ford, in a standard of care setting, what would you pursue for a patient like this? Is there a particular order that you would pursue? Would you give chemotherapy up front? If someone has upfront surgically resectable disease, would you go straight to surgery? What is there a particular approach that you prefer in this situation?
Yeah, I think it's it's a good question, and it's been kind of individualized depending on the institution to a large degree. But some form of trimodality therapy could be considered, either bimodality or trimodality, and by that I mean either neoadjuvant chemotherapy followed by surgery, and in some cases followed by postoperative radiation therapy to the residual areas where the pleura was, or alternatively upfront surgery followed by adjuvant chemotherapy. So there are two general approaches to surgery for mesothelioma. These include historically extrapleural pneumonectomy, which is a significant operation involving removal of the whole lung and the surrounding pleura, and does have a significant morbidity and mortality associated with it, except in very high volume centers. More recently, pleurectomy and decortication has been adopted by many surgeons and has a lower rate of morbidity and mortality. However, I think the choice of approach and the choice of modalities used are best made as part of a multidisciplinary scenario where discussions involving the patient, the surgeon, the medical oncologist, and radiation oncologist occur, and a decision is made then as to which approach is best.
Excellent. And was this the type of patient in general that you would try to hunt for a clinical trial for if the setting was correct?
Yes, I think so. I think there are some perioperative trials ongoing, and I think this would be an ideal patient, but particularly given that it's biphasic histology. I think exploring surgery with this patient should ideally be done in the setting of a clinical trial.
Excellent. And as the situation did actually unfold, this patient was enrolled onto an immunotherapy-focused clinical trial that did involve a multimodality approach incorporating surgery, chemotherapy, and with the option for radiation. So with that, I want to end and conclude with just a brief summary. So as we outlined in this session, patients with mesothelioma should be considered as potentially resectable with the correct workup that generally involves imaging with CT of the chest, in addition to a PET CT and potentially a VATS as well, to really completely investigate the mediastinum and completely assess for potential resectability. Once that has been determined, and ideally at a tertiary care center with significant surgical, medical oncology, and radiation oncology expertise, a multimodality approach can be pursued, and has generally been shown, while not in large phase 3 randomized studies, but in smaller studies, this type of approach has been shown to really improve survival in these populations. So again, I want to thank you for your attention and for listening to this session.